and welcome to the EADV 2025 in Paris. And it's my great pleasure to be joining you to talk about psoriatic arthritis for the dermatologist. I'm Dr. Laura Savage. I'm a consultant medical dermatologist based at the University of Leeds.
Hello, my name is Willy from West China Hospital, Sichuan University. I'm glad to be here in Paris to join EADV. And also it's the first time for me to join the EADV.
Well, welcome. It's a real pleasure to have you here. And I hope one day you'll also join us at the British Association of Dermatologists conference.
Pretty sure.
So we both have an interest in managing patients with psoriasis, but as part of that, of course, we've got to manage patients with comorbidities. And in about a third of patients, they have psoriatic arthritis. Now, perhaps I could ask you to start with, in terms of the dermatology clinics where you're seeing patients with psoriasis, how do you screen your patients for psoriatic arthritis? And if you were to identify somebody with PSA, how would you go about managing them?
Yeah, I think that's a good question nowadays. We're talking about psoriasis with comorbidities, psoriatic arthritis. For me, in my clinic, firstly, I regard every patient, new patients in our clinic with psoriasis should be developed PSA someday. So need to ask the questions, several questions. For example, do you feel pain with the joint? Sometimes the patients will say, no, I don't feel pain with my joints. Then I will ask, have you ever been feel pain with the joint? Few of them will answer, oh yeah, several years ago I haven't ever felt pain with my joints. That's very interesting. I mean, for dermatologists, even we ask the medicine history with the PSO patients, we sometimes need to in detail ask the questions. Not only the days they come to our clinic, we need to ask the medicine, maybe they have the PSO for several years, we need to ask them the whole history. That's the first, I think we should pay attention on it. And then I will ask the patients where they will, which joints they will feel pain, and how the features of the pain. Actually, I also have a question for you. Activity related to astral maybe should be not regarded as the feature of PSA, and angioplasty pain should be regarded as the PSA features. I'm not so sure. What's your comments on the different, activity related and rest related? What's your comments on the different symptoms?
Yeah. So in our centre, we screen all of our psoriasis patients, regardless of whether they've got mild or severe psoriasis. All patients get screened. When they come in, they do a screening questionnaire. We know the screening questionnaires don't have fantastic sensitivity and specificity, but what they are useful for is to remind the patient that you as the dermatologist want to know about the joints, and also allows you to facilitate those conversations. And you can then go into each of the questions on on those particular screening questionnaires. In Leeds, we use the PEST, but there are many available, the Topaz, the PAYS, there's plenty out there to then have those conversations, like you say, then go in and just, when they've answered yes to any of the questions, understanding a little bit more detail about them. Because for patients who are developing PSA, we know that typically their pain will be better when they're active, particularly spinal and buttock pain, if they've got sacroiliac or spinal involvement. But then when they are at rest, that's when they become stiff, and that's when their pain increases. So many patients will prefer to keep active, take up activities like swimming that are not putting additional mechanical loading onto the joints, but keep them active to give them some relief. So that can be helpful. And I think that's a very good discriminator, because many patients have pain and it can be very difficult to distinguish what's arthralgia from another cause from potential PSA. But I think that's where we bring in the rheumatologist to help us differentiate. But I think there are questions that we can do to add value in terms of working out which patients are more likely. So again, those who've got psoriasis affecting the nails, the scalp, who've got very severe disease, obese, a first-degree relative, even diabetes, those are the patients that we know are more likely to develop PSA. Then if they're developing arthralgia that doesn't settle between visits, increasing fatigue, these are the patients who are at risk of transition. But just clarifying, again, better when you've been exercising, worse at rest. Sure. Stiffness tends to be worse in the morning, it takes a while to get going. That can be quite a good discriminator to try and work out whether it's more wear and tear type of arthralgia or whether it's a true inflammatory cause.
I agree with you. And you have mentioned that most of the patients you will have the questionnaire for PSA. Maybe the nurses will finish the questionnaire. In my clinic, students will help me to finish the questionnaire to some extent. If they permitted, we will have the ultrasound, the peripheral joint examination. As you have mentioned that the pain of the joint is to find out if the patient's PSO will develop to PSA. And now rheumatologists have regarded it as as a subclinical PSA. And another important thing is ultrasound or images, ultrasound examination and the MRI to find out the image changes. That's also very important for dermatologists to find out the early stage PSA. And I think in most of the patients, all the subclinical patients, about 2/3 have abnormal image exchanges, but joint pain about 1/3. Some of them overlap. I'm not sure. What's your opinion? The patients at an early stage with the angio or only pain, joint pain, and
so imaging can be really beneficial. So if you've got a patient where you're suspecting psoriatic arthritis, then imaging is often involved in then confirming the diagnosis. The difficulty with imaging in PSAs, it's a very heterogeneous condition. So you can have just involvement of the small joints of the hands. You might be more probable to have it in the weight-bearing joints with enthesitis at the knee or Achilles or the plantar fascial insertions. But to actually screen patients, it's quite difficult. We've both done work looking at screening using ultrasound, MRI, etc., in patients who are presenting with psoriasis but no discernible joint pain, as you said. It's about half of patients coming to the clinic with moderate to severe psoriasis that have got some signs of joint inflammation. And even though it's silent, they don't have arthralgia yet, we can also see there's some structural damage taking place as well. That's about, like you say, for us, about 50% in your clinic, maybe 2/3 of the patients. What we don't understand is what then triggers a proportion of those patients to then go on to develop arthralgia and that prodromal PSA. Lots of theories around a second hit, be it a microbiome-related event, a stressful event, trauma. Lots of different theories that might tip people over into that prodromal event so that only 1/3 of the patients go on to develop classifiable PSA. But that's where we need a little bit more research. But I do think, it's in order to have prodromal PSA, it's got to be some ultrasound or potential whole body MRI imaging and that arthralgia. And that's quite an enriched population because those patients are easier to study in terms of progression to PSA because they're going to develop PSA within the next 1 to 2 years. The difficulty of studying, transition from subclinical enthesitis is you'd be studying a large group of patients for a very long time. So to fund a large-scale prospective study that goes on for 10, 15 years would be very difficult to fund and to continue and recruit.
As you have mentioned, that's a long time to follow up the patients. And would you mind to introduce us? What's your cohort? I mean, I think because you have done a long time on this field, so maybe you have a cohort on subclinic PSA.
Yeah, we do. Yeah, we have several cohorts. They tend not to have a sort of ongoing long-term cohort. We do have the PEDAR studies looking at predictors of disease activity going forward in PSA. And then, we're collating a cohort at the minute of patients as they're enriched for arthralgia as well. And then obviously recruiting those into particular studies just so we can understand more about that natural evolution of disease. Of course, what we're seeing as well is a lot of interest in actually can the way the dermatologist treats the patient for their skin, can that have an influence on the rates of PSA development? And in recent years, I think we've seen some really interesting cohorts which have suggested actually that treatment of patients with psoriasis with IL-23 or IL-12/23 inhibitors, those patients may have a slightly lower incidence of PSA development than TNF and IL-17 treated patients, which has slightly changed the paradigm about the way that we think about PSA development in patients. So for me, if I see a patient now with arthralgia or risk factors for transition and severe psoriasis, then I'm more likely to use an IL-23 inhibitor for those patients. However, if it's a patient who's got established psoriatic arthritis, then perhaps I'd consider a TNF inhibitor if it was a milder case of psoriasis, if it was a more moderate to severe, an IL-17 inhibitor. And that's how we differentiate in terms of treatment in our clinics.
So would you make a conclusion on it? I mean, nowadays we can read some data with different results.
I'm just wondering if the samples is not so huge or the observed time is not so long. Maybe it's a bit earlier to make the conclusion or something like that. I'm not so sure.
Yeah, absolutely. You know, we've only got kind of theoretical concepts. The data's coming from retrospective, claims databases that have been analysed, and they'll be fraught with limitations on the sort of data and the coding and so forth. So, I think this is giving us a snapshot and an insight. There are cohorts of patients with subclinical disease where their psoriasis has been treated, things like the AVEPSA study with secukinumab, my own Mustang study with ustekinumab. Italy has done work in subclinical enthesitis and arthralgia with guselkumab. All of these seem to be showing a degree of modification on the subclinical level. So I think the key take home for me is that if you are concerned about transition, get your patients advanced onto a biologic therapy rather than systemic or therapy or phototherapy for the skin.
Yeah.
I think if the patients have established PSA, I do, in every case where I'm wanting to make a switch, I don't delay treatment, but I will converse with my rheumatologist. And there's different ways of, I'm fortunate that I work in a centre, we have a parallel clinic. But, there are days that they're away, and there are other ways of communicating. Even if you're geographically spread, as long as you found somebody who's interested, you can drop them an email, you can give them the particulars about that case and say, I was contemplating this, what do you think? And I think as the patients with PSA progress through subsequent lines of treatment and become more difficult to treat, complex to manage, absolutely that becomes first and foremost the guidance of the rheumatologist. And it may be that you work together to combine therapies. In the UK, it's hard from a funding perspective, but there are patients that we will treat with one agent, such as an IL-23 inhibitor for the skin. My rheumatology colleagues may add in a JAK inhibitor. But again, you want that kind of cross collaboration to look at those individual patients, to make those informed choices for the really difficult to treat patients. And interestingly, GRAPPA has a difficult to treat project. We're both part of the GRAPPA group, and I'd encourage other people to join us. But there is a difficult to treat, complex to manage cohort being examined, aiming to try and produce some guidance to support dermatologists and rheumatologists with those more difficult to treat patients to see what combination therapies and strategies might be most effective.
Actually, nowadays, I think all around the world, lots of dermatologists and rheumatologists interested in these fields, especially how the PSO developed PSA, especially in early stage. And as we all know that from the 2011 to the last year, several important reference papers have published to have the different ideas on define the early subclinic. In 2023, Dennis and you both joined, have published the paper and subset the 3 stages, high risk stage and subclinical stage and PSA, clinical PSA.
Yes.
I think for me, in the past 10 years observation of these patients, I think the 3 stages will help us the clinic more easy than to. Also, I wonder if image change and joint pain, and the difference, maybe they are different in the future. Both have maybe early should be a short time to develop PSA. And in your clinic, would you separate them or both subclinic on PSA?
Yeah, so it's tricky because, as I say, it's impossible to undertake screening of every patient. The volume of patients that we see, and I really commend the work that you've done where you've really examined and performed ultrasound on a very large cohort. My understanding was you've got over 600 patients in your cohort, and that's incredible to collect that data because it's very time consuming and it actually requires a degree of high technical skill from the sonographer to identify enthesitis or clinical enthesitis, different from sort of wear and tear type changes. I think it isn't feasible to necessarily screen everyone. So the majority of the work that was now ongoing is in that more enriched population who've started to develop arthralgia. And that they're the ones that in the clinic we're more heavily focusing on in terms of really using that treat to intercept type strategy. You mentioned the work that Dennis and I did with EULA and the points to consider for the risk factors for transition. The reason for that was no clear consensus or definition about this sort of transition piece. And so it was more to not just help the clinician, but also help researchers to provide a degree of standardization within clinical trials in this area.
I think that's the most important thing to have the clinical research. We need to know the inclusion criteria. Maybe the different results just because include the criteria difference. Anyway, in the past about 10 years, make lots of progress in this field have developed, and for me, I'm interested in this, so ask a lot of questions for you on this field. And being a dermatologist in China, I would like to back you the first question for me. Yeah, we ask the medicine history and then do the examination and the questionnaire and have the test and have image examination. All these things will help us to try to find out the early stage of the PSA patients. And I think you have mentioned that GUAPA is a wonderful organization. And nowadays in China, I think some people, as dermatologists and rheumatologists, would like to know more, work on it. Hope you go China to introduce your work and introduce more interesting GUAP work to us.
Absolutely, I'd be delighted. But it's been a pleasure. Thank you so much.
Thank you.